Hey Internet, how you doing this morning? It is Tuesday, November the 1st, the day after Halloween. And I hope everyone had a great and safe Halloween evening with their family, friends, and loved ones. Been a while. There's been a lot happening over the past couple of weeks. First thing I want to do is just give a great big congratulations and two thumbs up actually for the Pain Science Division here in Canada and their successful running of the first Pain Unconference, which unfortunately I wasn't there for, but sounds like it was fantastic. All the feedback I've seen has been great. They had a wonderful lineup of speakers, but the neat thing about an unconference is that it's not just a function of bums in seats, listen to talking heads speak at you for a couple of hours, take your certificate and go home. The idea of this particular unconference was that after the speakers had maybe a bit of time to talk, they then came down into the audience, and the audience sort of broke up into groups, and they all worked through clinical problems together. What a fantastic experience that would have been. And again, huge congratulations to the group with the Pain Science Division of the Canadian Physiotherapy Association for putting that together. And I can't wait to see how it continues to evolve in the years going forward. I think it's far past time that we disrupt the traditional conference model. As I said, have been busy over the past 4 weeks. I've found myself in Japan, in Black Hawk, Colorado, in Edmonton, in Boston. It's been a bit bonkers, and I'm looking forward to a bit of a quieter November. Interestingly, the reason I was in Boston, which is something I'll probably talk about more in a future's vlog, is for the North American Spine Society annual conference, and we had a chance to talk about whiplash and advances in the field. And it got me thinking. So one of the speakers presented some work on treatments for whiplash, and this kind of just stimulated some thoughts in my mind, and I went back and I've had a student now, and I'm doing this with her, starting to look through the exclusion criteria for the majority of randomized trials in whiplash and neck pain that we've got. And it should be no surprise that when most people try to create a clinical trial, they do their best to create a fairly homogeneous and frankly fairly sanitized group of subjects. So what we're finding already in just the first handful that we've gone through, and I know this is the case from previous work in this area, is that, for example, pregnant women are almost always excluded. Unless the study is specifically about treating neck pain in pregnant women, of which there are very, very few, they're almost always excluded from randomized trials. And of course that means we really have no good sense of what to do with pregnant women when they have neck pain or get into a car crash. We also see, for example, most commonly they're published in English, and certainly the bulk of the work at least has excluded people who are unable to speak English or will say the native language, which of course raises issues around cross-cultural relevance and generalizability for a lot of the findings that we've got. People with significant comorbidities, whether they be psychological or physical, are often excluded. So certainly any kind of neurodegenerative problems or neuromuscular problems, but also any kind of organ disease, as well as a lot of times mental health conditions are excluded. So that sort of and I mean, there's more. There's others. There's a couple. One we found just yesterday, and this is not at all uncommon, excluded people who were intoxicated, whether drugs or alcohol were in their system, which probably rules out a fair number of people who get into car crashes. So anyway, it's sort of just a cautionary tale, I suppose, and something for people to think about, which is most of the findings we have, and I don't think this is unique to whiplash. In fact, I'm quite confident it's not. Most of the findings from clinical trials that we have are really applicable to quite a sanitized, homogeneous group of people, which realistically is probably a fairly small proportion of the population. And as a result, if we were to treat only according to the results of randomized trials, which really, if you think about it, is giving us group means and the differences in means, which means the mean change in group A was maybe better than the mean change in group B, is really applicable to a very small slice of the population. I don't even really know who these average patients or people are. I mean, a mean is only a mean because people fall in equal distance on either side of that. So something to think about. Certainly think about the evidence in the clinical trials when you're trying to come up with treatment recommendations. But of course, don't forget to look at the person in front of you and use your own clinical judgment and decide, are these trial findings applicable to this patient? I'll go out on a limb here, for example, and say that even though soft collars have been sort of demonized in the whiplash field, there's probably a few people who would actually benefit from a soft collar, if even for short-term use. So again, keep in mind that while clinical trials can give us a source of information when it comes to making evidence-informed decisions, at the end of the day, it's really the right treatment for the right patient at the right time, and that necessarily requires you to look at the person in front of you, to understand their story as best you can, to understand their goals and their values, as well as your own personal experiences, and wrap those all together to come up with the best treatment for that patient. So, some food for thought today. Till next time.